listening to this discussion on frozen shoulder. My name is Jeremy Lewis. I'm originally from New Zealand, and I studied in Australia, and I've been living and working in the UK for the last 20 years, working in the National Health Service, but also working in university as a professor of musculoskeletal research. So the title of this presentation is Frozen Shoulder, Don't Be Left Out in the Cold. And let's get started. So when we're talking about frozen shoulders, the way that I conceptualize how you might want to consider assessing shoulder pain is in a number of categories. So not a shoulder, possibly the cervicothoracic region or abdominal referral. Is it an unstable shoulder, stiff and painful shoulder, painful and weak shoulder? And of course we have to consider psychosocial factors, lifestyle factors, biomechanical factors, and the kinetic chain, and other variables as well as part of our assessment. But today's presentation is sitting very much within the stiff and painful shoulder presentation, and there are lots of different stiff and painful shoulders. Osteosarcoma, for example, lock dislocation, osteonecrosis, avascular necrosis, and OA would be examples of stiff and painful shoulders. But this particular presentation is talking about frozen shoulders. And there have been a lot of names used for this condition. The first person to talk about it was Duplay 150 years ago. And there have been a number of other names given to this condition where the shoulder becomes very painful, very stiff. And I guess the only really important name on this slide is what it's called in China and Japan, and that's the 50-year-old shoulder. Different health systems around the world are very different. I'm recording this during the coronavirus pandemic, and as you know, there have been internationally limitations to people's access to healthcare. In the United Kingdom, for example, you can't see a general practitioner, family doctor at the moment. You can organise a telemedicine consultation, and the doctor may, based on the symptoms that you presented to the doctor may say that it sounds like you've got a frozen shoulder, and at the moment there may not be that much that can be offered to that individual. So I guess if I had terrible pain, I wasn't sleeping at night time, couldn't move my shoulder, the first thing I would do is go online, check out Dr. Google, type in frozen shoulder or adhesive capsulitis, whatever the name I was given, and probably get around about 15 million different responses for the condition to find out people talking about it, providing advice. And what seems to be really popular at the moment are some home remedies, such as ginger, which is a natural cure for frozen shoulder, or so it's claimed. And I guess if I was desperate, I'd probably try anything to try and reduce my symptoms if normal pain medications hadn't been helping. Probably the one that's of most questionable benefit might be this particular website that promises a cure for frozen shoulder in one visit, and they're promising a 98% success rate on treating frozen shoulder in one visit. This company is called Trigenics. It's based in Canada, and they're claiming that this breakthrough medical procedure has largely become accepted and proven as the world's most rapid and effective treatment for adhesive capsulitis or frozen shoulder. And I don't know if anybody's heard of it, but they're making some pretty big claims. And I'm not quite sure what the treatment is, but I guess if I saw this gentleman standing with full elevation and smiling, could possibly be the father of the owner of the business. But I guess that would, to me, suggest that this particular treatment is effective. It's hard to know what the treatment involves. It looks like somebody destroys your kidney, and then for some reason you get held down by a number of different practitioners while somebody does something to your shoulder. What seems to be a feature of all these treatments is you need to be wearing blue gloves, and then after you've had this part of the treatment, it seems that you stand in a corner also wearing a blue glove while someone stares at you. And it's very hard to find any evidence for this procedure. We reviewed it in one of the papers we published, and we didn't find any conclusive evidence for it. So unfortunately, I think that sometimes people are making claims that haven't been substantiated by research, and maybe taking advantage of people who are experiencing this horribly painful and frustratingly restrictive condition. It's always interesting to try and understand what is causing a problem. If we have a look at the pathology, I'm going to just, for those who are interested, maybe suggest that you download a paper that Vicky Ryan and Hazel Brown led on, that we published a number of years ago now, 2016. It's open access through BMC Musculoskeletal Disorders. Just type in Ryan Frozen Shoulder BMC, MSK, and you'll be able to download the paper. And what we try to do here is to summarize what we understand is what people have researched to understand what is the pathology associated with primary or idiopathic frozen shoulder. And basically, we're really very uncertain as to actually what is actually going on in this condition. The first person to try and explain what was going on in frozen shoulders, as I mentioned earlier, is Dr. Duplay, based in France, and he suggested that maybe the problem was that the bursa, the subacromial bursa, was becoming stuck together. It was becoming adhered, almost like glued together, and that was causing the restriction of movement and the pain that people were experiencing. And that theory went on for about 50 or 70 years. And when we talk about management, it's interesting that the bursa is coming back as a target for treatment in this condition. About 110 years ago, we have X-rays introduced into clinical practice, and people started seeing strange areas of calcification above the humeral head, below the acromion, and a new theory emerged that the very painful condition, frozen shoulder, was caused by this newly observed phenomena, this calcification. In the 1930s, Dr. Codman, a very famous orthopedic surgeon from Boston, Massachusetts, published a book called The Shoulder, which, if you're interested, I love medical history, and you can read the book online at this website. But he rejected the bursal sticking theory, and he rejected the calcification theory, and said that difficult to explain what is going on, but he felt it was a contractive problem. He also said that it's certain to resolve, and we've been saying that ever since. And the reason why we've been saying that is that in this book, he has a small chapter on frozen shoulder, which he invented the term, and he reports that in 1933 he hospitalized 4 people. He tied them into elevation for 1 to 2 weeks, and they were allowed up out of bed once a day to do Pendura exercises. And he asked them at 1 or 2 weeks, do you need any more treatment? And I guess unsurprisingly, everybody said, no, I'm fine, I'm going home. I don't know if I would cope being tied up into elevation with this painful condition. So he wrote that everybody reports success in the treatment. And I wonder if that was maybe just a way to get out of this particular treatment. But based on a very small number of people, we've really been saying for a long period of time that it's a condition that will resolve. Another group of people suggested it wasn't a contracted shoulder. They suggested the term adhesive capsulitis. So they went back to a glue theory like the bursal theory of Duplay, and they suggested the capsule was becoming sticky and attaching to the humerus. They rejected the definitive contraction theory. And so there was a bit of a debate going on. Is it an adhesive problem? Is it a contraction problem? And that's really not 100% been resolved to this day. Lundberg was the first person to really do some major research on this. He's an orthopedic surgeon for his PhD. He looked at many hundreds of people with this condition, and he suggested that it was probably thickening and contraction of the capsule and probably not adhesions. And histologically, in many people, the contraction looks very similar to Dupuytren's contracture in the hand. And interesting that both of these conditions are more common in people with diabetes. And also, if we agree that we can't necessarily stretch out a Dupuytren's contracture in the hand, we have to also be quite wary of being able to say, that that we can actually stretch out a frozen shoulder if it has contracted. But we'll talk more about that as we go through. Codman and others have said it always gets better, but that's uncertain in this 7-year follow-up. We see 50 to 60% of people still have ongoing pain and movement restriction. In this study, on average at 4.4 years, but up to 20 years, people still have ongoing symptoms. And what we could probably say to people is that on average, it takes 30 months before you no longer feel disabled. Now, disability means doesn't necessarily mean you're not completely recovered. What it means is I no longer subjectively feel that this condition is negatively impacting on my life. It might be that you've still got some movement restriction and some pain, but I can get on with my life and I don't feel disabled by it. So whether people fully resolve, whether everybody fully resolves, is very uncertain. There's also some uncertainty whether you get better without treatment, even though research or pseudo-RCTs and quasi-experimental methods have suggested that may be the case. There's absolutely no certainty that that is the case. And so telling people with or without treatment they will get better is not founded by any particular research evidence. This is one qualitative study that's been published. No others have been published, but I have a number of PhD students who are currently doing research in this area of frozen shoulder, and we hope to contribute with some more qualitative research. But what are patients saying? Patients are saying that sleep is a major issue, pain is the major issue. They're frustrated by the fact that everybody's saying something different to them, that they would like the earliest possible resolution of the pain as possible. And we'll talk about some ways that we may be able to support the patient wishes. In terms of terminology, it's difficult to be certain exactly if a person does have a frozen shoulder or not. It's always a working hypothesis. But a number of people have suggested that we should divide frozen shoulders into primary and secondary frozen shoulders, where primary is idiopathic, where we really can't come up with an explanation for the contraction or the loss of movement and the pain. And there are a whole lot of secondary frozen shoulders, such as intrinsic, which would be associated with calcific tendinopathy, secondary systemic associated with diabetes, secondary extrinsic associated with ipsilateral breast surgery, possibly following mastectomy or other conditions, and secondary intrinsic iatrogenic would be a stiff shoulder following surgery. And there's probably another terminology that we could use, another definition that we can use, and that's called a muscle guarding or stiff frozen shoulder, and we'll talk about that in a few minutes. Many people have suggested that the condition goes through 3 or 4 stages, but in a paper in 2015, I suggested that we don't need to consider it as a 3 or 4 stage condition. We could really clinically just divide it into, is it a more painful or stiff phase of the condition, or is it more stiff or painful? And we can apply management to the clinical presentation. First of all, obviously, we need to try and make a diagnosis or hypothesis that the patient's got a frozen shoulder. Typically, the person would be around 50 years of age. They would have equal restriction of active and passive movement, must have equal restriction of active and passive external rotation, then of course other movements such as flexion and abduction. And I would suggest that external rotation must be limited by a minimum of 50% compared to the other side. And then the other variable that would be important for me, so 50-year-old plus minus, the active and passive external rotation and other movements restricted, 50% less of external rotation than the other side, and a normal X-ray for me would be as close as I can get to establishing a diagnosis. And then following that, I would try and categorize the patient into a more pain or stiff presentation or a more stiff or painful presentation. And if we start talking about the first presentation, the more painful than stiff, again, please, if you're interested, download this systematic review that we published last year. It's open access through the Journal of Rehabilitation Medicine. And we tried to look at, as comprehensively as possible, all the non-surgical interventions for primary idiopathic frozen shoulder. And in the stiff phase, there would be different management options than the painful stage. And the conclusion we made, based on the very limited research and the very poor quality research we have at the moment, is that in the pain phase, you can certainly try a number of different treatments, such as breathing and trying to distract the brain by getting the person to potentially roll a ball, listening to a something distracting the patient, such as a metronome, exercising the contralateral side, trying massage, trying virtual reality, trying the program for massive cuff tears. But if that's not working, I would very quickly suggest to the patient, after discussing the risks and benefits, to consider injection therapy, because that, based on our systematic review, seems to be the best treatment in the painful stage, and it doesn't seem to work after about 6 months or when in the stiff phase. So as long as the patient understands the risks and benefits, and there are a lot of risks, it may be the most appropriate treatment to suggest. And what we have been doing is we have been doing a series of injections. So if, in the United Kingdom, physiotherapists are allowed to perform injections. I've also trained as a sonographer, so I perform my injections under ultrasound guidance. And you can see here a injection, that's the needle, into the glenohumeral joint. You'll see the injection happening at the moment into the joint. So we would start with a glenohumeral injection. We do that with the patient inside lying for the patient's comfort. We then roll the patient onto their back, and we would then perform a subacromial injection directly into the bursa. That combination, to the best of our clinical knowledge and the research, seems to be the best combination to reduce pain and restore movement. The addition of the subacromial injection by itself doesn't seem to do much, but when you add the subacromial injection to the glenohumeral injection, it's the subacromial injection that seems to help most with increasing the range of hand behind back. But as I mentioned before, these injections will really only work when you, if you administer them, if you offer them in the painful stage, as long as the patient understands the risks and the benefits of the procedure. Our systematic review goes through some of the papers that we used in coming up with our suggestions, and I will leave that for you to read. In the stiff phase, injections don't seem to have the same benefit, and so you may want to be considering other interventions. One of the things that physiotherapists will commonly do is mobilize the joint, and we've all seen improvement in our patients with joint mobilization. If we think about the forces that we can administer during a mobilization, it's probably not much greater than about 20 kilograms, but Ito's study suggested that to stretch the posterior glenohumeral joint, the force required was in the order of more than 680 kilograms. And if we think about that, we're not getting anywhere near those sorts of forces in our mobilization procedures. And if we also think about it in perspective, the world's heaviest world record for deadlift is around about 500 kilograms. And the good news here is that the weight of the heaviest deadlift is less than the force required to stretch the capsule of the shoulder, because if it was greater, you'd be leaving your shoulders behind when you try to lift do the deadlift. So it's possible that we're seeing improvement with mobilization for a reason other than stretching the capsule. And one possible reason could be muscle guarding or muscle stiffness that's not actual capsular stiffness. And if we have a look at Louise Holman's small case series, if we get this to play. So this is a woman who has got a frozen shoulder. That is her active range of movement of her frozen shoulder. She's now in an operating theatre, and that is her passive range of movement before she goes under general anaesthetic. She is now under general anaesthetic, so she's asleep, conscious, and she has now got full range of movement when the procedure is performed passively under anaesthetic, which suggests that the reason for her stiffness was actual muscle guarding and not necessarily a capsular contraction. So maybe what we're seeing when we perform our mobilization techniques or over time is that the muscle guarding may be settling. And again, we've got some research underway with some colleagues in America looking at this in more detail. So some colleagues in America, colleagues in the UK, looking at biopsychosocial reasons for having muscle guarding. And again, you can have a look at our paper, which discusses findings from RCTs of low risk of bias. And in the stiff phase, as we mentioned, injections are probably not beneficial. They seem to work best under 6 months. But there is evidence, and we found a number of papers that suggest stretching, mobilization, home exercise has short and long-term benefit. And I will leave you for those to read them. So it would be wrong to say that there's no place to play with mobilization, stretching, and home exercise, but the quality of the research is not amazing. And we only found 3 studies of low risk of bias to draw that information from. And again, I'll leave those to you to read. There was also an interesting paper published by colleagues in India, and they took a small number of people, 42 people, and randomized them to 2 groups. The first group had joint mobilization and TENS, and they reported in 1 month a 30-point reduction in the shoulder pain and disability index, which by itself is pretty phenomenal reduction in disability. In the other group that also had the joint mobilization and TENS, they also had a strengthening program, and they reported a greater than 50-point reduction in the SPADI, the shoulder pain and disability index. Now, the quality of the study was reasonable. There was probably not enough people. There was not a long-term follow-up. But what it suggests is that either it's mapping natural improvement or there is some advantage to mobilization and TENS, but the strengthening group actually had the greatest improvement. And if you look at the exercises that they used in their strengthening program, it looks really similar to what you might consider, or some people might consider, for a rotator cuff rehabilitation program. And you can see the parameters that they used here. So maybe what this group have also identified is that muscle guarding may be a reason for the frozen shoulder, the stiff shoulder, in a number of people, and maybe it's a component in many people's frozen shoulders, and a smaller subset go on to actually have a capsular contraction, and we don't know at the moment how to differentiate those subgroups. So as I said, we're doing quite a lot of research at the moment in this area, and I would suggest that in the stiff phase that you might consider very heavy slow resistance rehabilitation to see if it can improve range of movement, improve function, possibly getting rid of some of the stiffness before you start other techniques such as mobilization or perform them in conjunction. But certainly try heavy eccentric loads to reduce the patient, to see if it has some benefit for the patient in terms of movement, in terms of pain reduction, if there is still pain in the stage. What else? Many people are considering hydrodilatation or hydrodistension as part of the intervention. This was a procedure that I learned to do in 2010 and did it for many years. But more recently, I've stopped doing this in favor of the 2 injections that I mentioned earlier in in the painful stage. And if we have a look at some of the research on hydrodistension, it would suggest at 1 month there might be some benefit in that group. And this is a large injection of sterile saline, isotonic saline into the joint. And of course, there's risks associated with that, such as infection, such as damage to the capsule. And there's no seemingly long-term benefit at 3 months or 6 months. So I'm not quite sure if we, at the moment, can justify a hydrodistension procedure based on the small benefit in the short term. But that would be something that would have to be discussed with the patient. We have just submitted a systematic review looking at surgical management of frozen shoulders, and at the moment there is no strong evidence for any surgical procedure. All the studies that we included were at high risk of bias. This is a capsular release procedure where the surgeons would cut around the capsule to try and restore movement. And certainly it could be something that is considered. If non-surgical interventions don't work, there's no evidence that if non-surgical interventions are unsuccessful, that the surgical interventions will be of any benefit. But it's not something that I'd recommend the patient would do before trying non-surgical intervention. And obviously we need a lot more research in all areas of management of this condition, and without any question, surgical management as well. So that's the end of the presentation, and I hope it was of some interest to you, and thank you very much for listening. Thank you.